Hi, I'm Learne Durrington and I'm the CEO of the WA Primary Health Alliance. And for those of you that don't know, we operate the 3 primary health networks here in WA. And we have an opportunity to talk about the patient-centred medical home today. And many of you will have heard the Commonwealth announcement around the healthcare home, and that is a trial that the Commonwealth are going to roll out, and in WA that's going to happen in Perth North. However, that's one of the strategies that is on a progress towards the patient-centred medical home. Today we have with us 2 very experienced, my words, people who have been implementing the patient-centred medical home in Western Sydney with the Went West PHN. And they've been on a journey for a couple of years, so they're a bit ahead of us, and they have some great insights about what's worked, what are the key learnings, what they might do differently, and we're going to talk about the underpinning principles of the patient-centred medical home and what does that really mean for general practice. In WA, we are using the term comprehensive primary care, and that's because we're at the beginning of this journey, not as far down the track as others. But conversely, there's a range of guiding principles and strategies that all align to help practices consider how they may want to either optimise their practice to move towards the patient-centred medical home, or indeed for those practices who are well advanced on this type of journey, go there much quicker. So I'm going to introduce you to Ian Corless and Dr. Walid Jammal, and we're going to talk about the principles that underpin this model, but moreover, what does it mean for general practice and what's been the experience of Western Sydney? Walid, could you just start this conversation by talking to us about the international experience and the key elements around the patient-centred medical home?
Sure, Leanne. One of the things that when I first went over to the US to have a look at some of these models that they've developed there, that struck me was the absolute commitment to holistic, continuous and care for all of their patients, not just the ones that, with chronic disease. So that they really, and their drive for continuous sort of quality and the high quality of care that they like to provide, their drive for commitment to those patients and the patient's commitment to them, and their absolute dependence on each other as a team to work together, and their shared responsibility that they have. So that certainly struck me from the international models, and as Atul Gawande I think says, is medicine is a team sport.
Yes.
It really is a team sport.
Yeah.
And that sort of culture of teamwork, improvement, quality, safety and commitment is ubiquitous amongst all of the sites that are really embraced and transformed into the patient-centred medical homes.
So building on that, Wally, could you just summarise what you see as the main principles and talk to that term we hear about the 10 building blocks and how that connects?
Look, again, it took me a little while to really understand where the 10 building blocks have come from and what they're all about. The ultimate goal really of any organisation that's transformed and looked at the patient-centred medical home model to aid in that transformation is really the quadruple aim, which is the population health, improvement in patient experience, reduction in costs, and improving provider satisfaction. The 10 building blocks is a framework that allows you to get there. Now, we could spend all day talking about the building blocks, but we haven't got all that much time now. I'll concentrate on the essential criteria. The first and most essential is actually leadership, which means someone in an organisation has got to be committed to change management, and to that vision of the quadruple aim. The second is patient registration, because an essential part of reaching the quadruple aim is population health management. Now, what does that mean? It took me a little while to understand really what that means. If I can put it simply, it's being responsible accountable for all patients that would call you their doctor, whether they come and see you or not. And it's kind of a paradigm shift in thinking here, that really there's a group of patients out there that would want to see me as their doctor and call me their doctor if they were asked who your doctor is. And so I'm responsible for their care, whether they've actually come in or not. So that population health management is ultimately dependent too on registration of patients or empowerment of patients with individual providers and the practice. And then when you know who your population are, then you can actually then drive quality improvement with the use of data. And so the third element of the building blocks is data-driven improvement. As I've said earlier, none of that is achievable. No single doctor, no single provider can do it all on their own. And so that's where the team comes in, and using the team to the best of their ability, to what the Americans say is their top of their license or their top of their scope of work. And when you think about it, a lot of our health professionals, doctors, nurses, allied health professionals, do a lot of work that they're actually, that they're more than trained to do, but sort of do work that is actually should be done by other people, so they can concentrate on the work that they're really trained to do. And so using people to the top of their license in a well-coordinated, team-based approach that uses data-driven, that concentrates on data-driven improvement is absolutely crucial. They're sort of the essential criteria. There's 10 of them. I'm not sure what the last one is, but it's the practice of the future. I'm not sure why they put that there, but they're the sort of essential elements.
Yes, so Wally, you've raised some really key points in that description, and even for me, listening to you, picking up that, and it's not a tension by any sort of stretch, but we often hear in the dialogue, this is all about coordination of care for people with long-term conditions rather than the full population. And I do appreciate that for general practice, how they balance that is a challenge. And so, sounds all sort of not simple, but it makes coherent sense. But Ian, I'd be really interested to hear from you what strategy and processes you've used in Western Sydney to take this forward.
Sure. Happy to, Leanne. I think the first thing for us as a primary health network and formerly as Medicare Local was really to try and have an infrastructure that would best support general practice. And a lot of things would be very common to people. We wanted a common data extraction tool. So we've pretty much standardized in our part of the world on a data extraction tool because Wally alluded to the fact just how critical data is. We wanted to have an electronic shared care plan that would allow the team of clinicians to be able to share information more effectively. And then to have a point of view on what was best practice, which really Health Pathways provides for us. So that was work that was happening in parallel, but certainly was fundamental to us being able to support practices on this journey. So it started with that in terms of some basic infrastructure, and then it came down to how could we best support and enable practices who wanted to come on this journey. And that starts off really with, first of all, how you let people understand what the possibilities are. Because I think Wally would agree in the early days, people struggle with the concept. And I think many GPs feel quite rightly they deliver good care, but it's only, the more you study it, the more I think, well, maybe there are things we could do differently. And it surprised us, well, it shouldn't surprise us, but it took some time for that to be processed and reprocessed. And then, so it was really for us to develop a program of work which was anchored in the 10 building blocks, and I'd have to say our subsequent experiences still the best way to go. And to be able to work through that in a fairly structured way and bring people along on that journey and do it kind of one block at a time. And I think what we've learned over this last 2 years is we probably need to have more reinforcing mechanisms and really try and get everybody to move. I wouldn't say in lockstep because every practice is different, but certainly a commonality of approach that people feel they're moving along at roughly the same pace. Now, as much as you can, that's not always possible. And I think within that you can then start to consolidate that change process. But what we have done, we've run a whole series of programs on leadership and continue to do that. And it's leadership and management. Because it's those two coming together, and fundamentally, although so many GPs are passionate about what they do, sometimes they're not great at communicating the why they do it.
Yes.
And I think what we found is the really fundamental starting point here is to equip GPs to be able to convey what they want to do, to be able to convey what they want to do with the teams, to engage them in that discussion. And we find time and again, and still ongoing, it's something that's a challenge and something that still needs to be better refined and implemented as we move along on this journey.
And you've mentioned, Wally, the notion that the importance of the data and the patient enrollment. Could you talk a little bit more about that, just in detail, about what that actually means for a practice?
Sure. Look, I mean, in the current context, I mean, it's hard to, in the Australian context, patient enrolment will mean completely something different to what it means overseas.
Yeah.
Clearly, we can't enrol patients and stop them going anywhere else. What it means to a practice on the ground, though, is, and it depends a little bit on the size of the practice. When you're talking as a solo practice, all patients are there as enrolled with you.
Yeah.
But certainly in the larger group practice, patient enrolment means asking the patients who their preferred the GP is, and allocating, you know, at an administrative level in the software, that GP's name to that patient. So that even though that patient may actually come and see other GPs in the practice, as they should, and they could, and they would, that sole GP, that person, that GP of their choice, takes ownership of that file. And so when you're then looking at the data, then it then allows the individual doctor, as well as the group within that practice, to take ownership and responsibility for the quality of care provided to that patient. Look, with time, I think that can evolve. It is an evolving practice. But then you've got the data. I mean, when you first look at data, you sort of look at it and you go, that can't be mine. That can't be true. So data is enlightening on and reflective, not on necessarily on the quality of care, but certainly in the direction of the quality of the records at the very least.
Yes.
And so the first thing that we've done, certainly in my practice, and it's taken probably a year and a half of hard work, is data cleansing. Really tidying up the records and tidying up the data in the records, so that we can actually then use the data to actually say, well, here's where we are, and then be able to define where we want to be. All quality practices practice quality medicine, but if you have that drive of continuous quality improvement, you've got to have the data. You've got to know where you are.
I'm really interested to hear from either of you about engaging or meeting with those practices who are fearful or sceptical, and what you might have observed or learnt from those interactions from those practices or GPs who were fearful of this type of change.
Well, maybe they can start. Well, I think all change, you know, most people are concerned about change and often resistant to it. And I think, you know, you can get very enthused about the whole idea of the patient-centred medical home as that beacon on a hill. And I think it can seem like an enormous transformation. And I think it's, you know, it comes back to how do you eat the elephant one step at a time. And I think, you know, as you work through those building blocks, you may not ultimately do the whole journey, but you'll have a better practice because of it. So I think we've got to make it less daunting, because I think some find it daunting. There's also as well, you know, some people say, well, what's the need to change? And I think that's a fundamental business decision for practices to say, how do you see the future evolving, and how do you see the position of your practice within it? And that's a very fundamental question, and different practices will take different routes, but it needs to be a considered route. And I think as they overcome that fear, part of that fear is really not perhaps having taken the time to think about, well, where is my practice going, and how do I want to lead it there, and how can we assist them to do that with, you know, with minimum fear and anxiety, I think.
Would you add anything to that?
No, look, I mean, that's well summarised, really. I think change is scary, no matter who you ask for change, especially And I say especially for GPs. No, that's not, as a GP, I'm not trying to insult my own profession here. But when you're doing a good job, or you think you're doing a good job, and you're working on at the coalface, at the front line, and you're trying your absolute best, that your best should be good enough.
Yeah.
And so for someone to come in and say, I'm going to question what you're doing, I want you to question yourself what you're doing, why you're doing it, how you're doing it, and by the way, here's a change for you, why don't you do things differently? The first question is why?
Yeah.
What's in it for me? And so answering that question of what's in it for me is really, really hard. And if that isn't answered well, you've lost the audience.
Yeah. Yes, it seems that that notion of asking that question and also the leadership are sort of inextricably linked and fundamental, aren't they, to this process? How would you summarise, either of you, and maybe they're the same and different, the key challenges that you've faced over the last couple of years in taking Western Sydney, the PHN, through this journey, for want of a better word?
I think because it's not just changing practice, it's changing the primary health network.
Yes.
Because what you very quickly realise is that you've got to be ready to upskill your people to be able to do this.
Yeah.
And we have tried very hard to do that. So all of our folks who are supporting practices on the ground will go through the same programmes and so on, often in advance, so that they're at least one step ahead of the curve. So I think that's been really important because it almost it imposes as much change on us as it does on the practices.
Yes.
So we're not asking others to do what we're not trying to do ourselves.
Yeah.
And we've had, from systems, processes, people, there's been a major rethink and rework of that's ongoing, because we constantly have to fine tune and adjust to try and optimise all of this. So I think that's been a significant challenge, but I think also a tremendous growth for us as an organisation as well, which I think people have been very committed to and very, very positive about, really trying to drive for better quality care in Western Sydney.
Yeah. And I guess my observation is, watching the PHN, this is not a silver bullet. This is a well-crafted, my words, but you have to draft a whole range of coordinated strategies that come together and assist both the PHN and practices. If you were to say there's been a couple of one or two standout successes, what might they be?
Look, there's challenges and successes. The challenges, and if I had, as Ian said, if we had our time again, we'd do things differently. Yeah. Look, recently we had to go back and look at the why. Why are we doing it? Why are we driving this? What's our vision? Why are we going for that vision? And in the last couple of weeks, we've hit. I've certainly hit, as a practice principal and owner, I've hit a good place with my staff. They can finally see the why, and they're certainly coming along for the journey. As I said earlier, it's taken 1.5 years of hard work to clean up a lot of our data, and we can start showing results with that.
Yeah.
And so when they start seeing the results, they're in black and white and in graphic format and nice colours, they can actually appreciate the hard work that they're doing.
Just one comment I'd make. You talk about successes. For us as a PHN, success is starting to see that greater focus on data, starting to see better quality data, and starting to see practices really interrogate that to say, how can we make ourselves better using that data? That's happening. When we've tracked that, we've got some nice metrics that show that steady improvement in quality of data. So those are successes. I think a success for us when we see GP, particularly practice owners, move from saying, well, why would I bother, why would I do this, to that transition where they say, I get it, it's scary, I'm apprehensive about doing it, but you see that they can start to see the potential value in this journey and start to warm up to the task in hand. Those are successes, the kind of milestones along the way that you can say we're making progress. So those have been some of the standouts.
Yes, and for us, we're at the beginning. We have great partners with RACGP and WAGPET, which is the GP training organisation, and we will work collaboratively with them, and there are opportunities in that, but it is a journey in and of itself. And my sense is we'll be talking more often about how this unfolds, because no doubt there'll be learnings we have that we'll be happy to share, but conversely, we're interested in yours. So thank you very much for your time and commitment, and we'll work together on this as we go forward.
Thanks, Leanne.
Thank you.